Good afternoon and welcome to our educational webinar, Sleep Navigators and Post-Discharge Sleep Care to Reduce Readmissions. My name is Rachel Bohr and I'm the Senior Marketing Director at Enzo Data. Robert Miller is an innovative and results-driven operations and business development executive with over 28 years in the sleep and home respiratory healthcare industry. Robert's passion is to implement strategies that enhance the patient experience, improve care delivery, and promote better health outcomes. Robert is currently the Vice President of Sleep Business with Apnea, one of the largest HME providers in the US. He is also a co-host of the podcast Sleep Tech Talk. Robert is based just outside Charlotte, North Carolina, and loves spending time with his wife of 33 years as well as his 6 children and 5 grandchildren. He is also an avid UNC Tar Heel fan. And with that, I am going to pass it over to Robert.
Rachel, thank you so much. I appreciate the opportunity to talk about something I'm extremely passionate about. I wanted to have the disclaimer in the intro about me being in just outside of Charlotte, so you would understand the southern accent and try to stay with me as we navigate through this presentation today. All right, let's jump right in. So again, Robert Miller. I'm a registered sleep technologist. I was able to take and pass my registry examination back in the early 90s, and have been in this field for a long time. If I'm not connected to you on LinkedIn, I wanted to give you an opportunity to use your phone to scan the screen, the QR code that's on the screen, and I hope that we can get connected and dialogue and collaborate about things related to sleep. I like to post a lot of content related to sleep, and I do work for Apnea, so but they're nothing that I'm going to necessarily talk about today is specific to Apnea. It can certainly be, any program and any home care provider that's in the country. And then also the Sleep Tech Talk. I hope everyone has at least listened to a few of the episodes. And if you're not currently subscribed, we'll give you an opportunity to do that a little bit later in the presentation. So I know that most everyone who's probably on this call today has seen information related to the number of patients who are undiagnosed and untreated. I've actually seen an updated number, and we typically know that number to be about 80% of patients who potentially have obstructive sleep apnea still remain undiagnosed and untreated. But I saw a new number recently. There's a joint venture between ResMed and a company that's part of Google called Verily, and they're reporting 90% of patients who are potentially sleep apnea candidates remain undiagnosed and untreated. So there may be some updated information, and even beyond this particular slide, which has been a part of I would say multiple presentations that have been given in sleep since it came out in 2016. But it also does break down, nicely, I think, into the 3 different subcategories of the patients who are diagnosed, the 3 primary treatment options that are available to patients. Obviously, CPAP is the gold standard. We know that, with the Philips recall, the oral appliance treatment option has certainly become a greater, opportunity for patients to receive treatment. And then there is, of course, options that are on the rise as well. All of these different health issues that patients experience, hypertension, heart disease, diabetes, asthma, insomnia, there's motor vehicle accidents, both commercial, non-commercial, that all involve sleep and something to do with sleep. So, the ultimate goal there, the meaning of this particular slide is for me to say this, is that, I don't think that sleep is necessarily a pillar of health. I really truly believe that sleep is the foundation of health. And you can almost take just about any health condition and somehow tie it back to sleep. I actually posted something on LinkedIn this past week that reflected issues with bone density related to patients who have sleep apnea. So, even something that you wouldn't necessarily correlate in the past, those things are certainly becoming part of patients that we know, potentially have obstructive sleep apnea. So, one of the things, it's interesting with the poll that we saw a number of primarily most of the folks who are on this call don't necessarily screen their patients today for OSA. And, why is that? We know that it's important. We know that it's a foundational part of a patient's health. So, why are those programs not more common in healthcare settings? Well, there are a few barriers and challenges, and I thought we would spend just a few minutes talking about some of those. So last year, the U.S. Preventative Services Task Force presented their recommendation related to sleep apnea screening patient populations that are not necessarily symptomatic. And, it was a little bit confusing because I think that in general, most of us who are involved in sleep medicine would have expected the outcome to certainly be very different than what was ultimately presented. So, I'm like Ron Burgundy here saying, make it make sense to me. They absolutely said that they believe that adverse health outcomes associated with untreated OSA include cardiovascular disease, cerebrovascular events, type 2 diabetes, cognitive impairment, decreased quality of life, and motor vehicle crashes. Severe OSA is associated with increased all-cause mortality. So why wouldn't we screen our patients? Well, ultimately, the conclusion was there's insufficient evidence to recommend for or against screening for OSA in the general adult population. So it was really not very helpful, I think, to us as an industry that there just wasn't enough. There wasn't enough data and studies that were done, I guess, appropriately that could be included in the overarching, ruling from that USPS task force. So, unfortunately, it eventually just sort of leaves it up to the clinicians should use their own clinical judgment regarding whether patients should be screened for and how to screen for OSA. But wait, there's more. We've always got lots of challenges. So there's more challenges. And, one of the things I saw that I wanted to at least bring to this group is that, back, and this was really during the pandemic, Zoll Innomar had a survey, a patient survey that they did related to sleep apnea and sleep issues. 89% of the respondents believed they knew what sleep apnea was. 33% said that they could reduce the risk of associated, they didn't know that they could reduce the risk of associated cardiovascular disease, diabetes, and stroke by treating their sleep apnea. So they knew sort of what it was, but they didn't know the significance of getting their sleep apnea treated. 24% of the respondents didn't know that the existence of home sleep testing. I think there's still I think there's still a lack of information of the availability of and the ability for sleep labs to be able to get patients diagnosed in the comfort of their own home. If prescribed or required, 56% of the respondents would choose a home-based testing solution. And we know that, after post-COVID, there certainly has been a shift from, in-lab sleep testing to more home sleep apnea testing, especially for those patients who are candidates for obstructive sleep apnea. So some of the top three concerns of patients also was the cost associated with the test, the inconvenience of going into a sleep lab, that certainly would play into it. And at that time, it was also COVID fear. I think we've probably moved away from some of that. 25% of the respondents stated that they were either unaware that snoring could be a sign of a more serious health issue or didn't believe that it was true. So, I know that I've even heard people use the terminology that, I'm sleeping good when I'm snoring. And so they don't necessarily associate snoring with being a serious health issue. And then 23% suggested that they would think twice before seeking medical help for a sleep problem. So you've got a segment of patients that wouldn't necessarily, even if they know they have an issue, they wouldn't necessarily do anything about it. So we know that there's still some education and things that we need to do on the sleep side to increase the public awareness. Some other important statistics I thought that I would mention is, and these are part of some of the more academic and clinical type of data that is available to us, that 80% of patients remain undiagnosed and untreated. $19,566 is the mean total annual healthcare cost for those with untreated OSA. those are real dollars. And when you associate that with a patient population, then you're talking about significant dollars. 9 years fewer life expectancy for patients with untreated sleep apnea. I think that is an absolute number that, we don't want to necessarily use fear tactics, but we want to make sure that patients understand the potential mortality and reduce life expectancy with remaining undiagnosed and untreated. So 209% higher than average per member per month total medical spend for Medicare beneficiaries with OSA. Patients who are undiagnosed and untreated, they cost more to the healthcare system. That one particular data point to me is why healthcare systems, hospitals, physicians, sleep labs, home medical equipment providers all need to get engaged with proactive screening for patients with sleep apnea. And then 67% reduced annual per patient diagnosis treatment costs versus leaving patients undiagnosed. So, these are telling numbers that we need to do a better job of going after these undiagnosed patient populations and getting them through the process and getting them on treatment as quickly as possible. So if you start to do some searches related to managing chronic disease, and maybe in your healthcare system or even in your own general practice, you haven't thought about sleep as a chronic disease. I truly believe, and Rachel and I were talking earlier about another person involved in sleep medicine who's, I think, doing the next webinar for InsoData, is a super passionate person. And this is something I'm passionate about, that, I think that we have to include sleep apnea as part of any one of these different programs that are out there related to chronic disease patient management. These patients need to have, if you see it in the top left-hand corner, you've got heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, chronic kidney disease. That is an OSA patient population without a doubt. So we've got to start changing the narrative as it relates to, what sleep apnea is and how we need to include it in that long-term management of these patients who have comorbid conditions. And, of course, I'm from the South, so, can I get an amen for that? One of the things I thought as I started to prepare this presentation was to look at, I know that there's a lot of buzz about AI and the chat GPT and open AI types of intelligence that's available to us today. So I thought, well, let's ask the question to these, to these different programs and see what their response was. So I asked the question, why should a healthcare system implement a sleep apnea screening program? And this is what ChatGPT had to say. Early detection and treatment, improved patient quality of life, reduced healthcare costs, improved patient satisfaction. I think those things are significant enough to justify the need to implement a sleep apnea program in any healthcare system. I would hope that we would want what's best for the patients, and that sleep apnea screening and treating their sleep apnea potentially would be something we would want to look at. Another question that I asked, what are the benefits for payers and healthcare systems to proactively identify, diagnose, and treat patients for obstructive sleep apnea? Let's see what they say here. Reduce healthcare costs, improve patient outcomes, increase patient satisfaction, enhance population health, improved efficiency. So in summary, proactively identifying, diagnosing, treating patients for OSA can provide several benefits for payers and healthcare systems, including reduced healthcare costs, improved patient outcomes, satisfaction, enhanced population health, and improved efficiency. So I think that even the ChatGPT program agrees with me. But how do you get started? This is one of those things. It's you ask the question, how do you eat an elephant? One bite at a time. So this is at least my recommendation. If you have any interest in getting a program started in your healthcare system, that this is at least one way I think is probably at least a way to look at implementing a program. So, start with screening. Start with a high-risk patient population. So you don't have to start day one screening every patient in the hospital system. Maybe it's that you target the patients who are part of or potentially might be a readmission penalty to the hospital if that patient were to readmit after their initial admission. So, pick a high-risk patient category, start with a simple screening program, even if you have to start with paper. If it's a paper stop bang survey, but limit the initial implementation period to just a couple of weeks, maybe 2 to 4 weeks. So that way there's not this, it doesn't feel onerous to implement the screening program. And because I think sometimes that may be a barrier to getting the conversation started, because then it becomes, we're going to have to screen every patient from now until the end of time. And it just seems like the scope of the project becomes much larger versus, this very consolidated, targeted patient population. And then you take the results of those, of that initial survey, and that's where you have to get buy-in by hospital leadership. So you've got to have that internal champion. If you're the manager of the sleep lab, if you are the head of a respiratory department, that's where you want to get the hospital leadership to buy in. Maybe it's the medical director of the sleep program or the medical director of the respiratory program who's also advocating on your behalf to get this type of program started. So once you've made your case for implementing a sleep apnea program, a sleep apnea screening program, then the next step is truly, what type of EMR do you have? I know that there are current EMR systems that healthcare systems have in place already, like Epic and Cerner, that do have some type of sleep apnea screening that is built into the program. In some cases, I have seen it that there's a stop bang survey that's already baked into the hospital's EMR, but it's not mandatory. So it has to be mandatory for at least for certain patient populations. I think once you sort of make the case that then it probably will be accepted to roll it out to a larger group of patients. But the goal is that you have to have it be mandatory, and so that there is no way that a patient's not at least going to be asked the questions, and then the results are going to have to either go to a sleep navigator or to someone who's going to help manage the patient. We'll talk about the diagnosis and the treatment piece in just a few minutes. The other thing to consider is, does the sleep lab have capacity to even if you were to generate 100 new referrals to your sleep program, can your sleep center actually perform enough? Is there capacity to perform that number of sleep studies currently? So you have to plan in ahead of the rollout of this particular program, because you are going to increase the number of sleep tests that occur at your facility, both in lab and home sleep apnea testing. So you have to take those things into account. Do you have the capacity from a physician standpoint to be able to handle, these patients? Who's going to do the follow-up care from a physician standpoint? Is there a current backlog for your sleep lab? If there is a backlog at your sleep lab and you were to implement this type of program, it's only going to exacerbate that problem. But I think that at some point you've got to start looking at each one of the individual patients and then begin to triage, can this patient that was originally ordered an in-lab sleep test be diagnosed with a home sleep apnea testing device because they were referred to the sleep center, with the possibility of having sleep apnea. So you have to take all of those things into account, and it's sort of a step-by-step process to get to a place where you have this program implemented and to have it be successful. So let's talk about the Sleep Navigator. I mentioned it just a minute ago, but let's talk about what the Sleep Navigator specific roles are. And so if you implemented an OSA screening program, then one of the ways to be able to manage the patient would be to have a Sleep Navigator. Take the patient from that positive screening and then essentially navigate the patient through the diagnosis and treatment process, and then on to monitor and report. We'll talk about that in just a minute. But, initially for patients, and this is one of my recommendations, if you have a hospital that already has a sleep apnea screening program in place, I actually found this OSA protocol, and I'll talk about it as an example in a few slides. There's a hospital, a very small hospital, by the way, that when they implemented their stop bank survey, they implemented this OSA protocol so that they were protecting the patient while they were in-house there at the hospital. They would put a wristband on the patient's arm so that everyone who's involved from a clinical care team standpoint is able to identify that patient easily as a sleep apnea risk patient. So let's say that the patient's admitted for one issue and then at some point needs surgery. When that patient goes to the surgical suite, they're going to have that sleep apnea wristband on. So anesthesia is going to know they need to treat that patient differently as they come out of surgery and are in the recovery room. But look at the OSA protocol here. These are simple things to do, but it certainly brings a lot of attention to and protects the patient while they're there in the hospital. Elevate the head of the bed to at least 30 degrees. Avoid supine position. It may be that the physicians want to manage how their multimodal pain management for the patient. So they may want to consider different pain management options for the patient. Obviously, they want to keep the patient, monitor and then maintain the SpO2 above 90%. And potentially, in some cases, and depending on the potential severity of a patient, even consider entitled CO2 monitoring. And then, ultimately, it may be that the patient needs to have either CPAP or BiPAP while they're there in the hospital. So we've put a wristband on the patient. We've implemented the OSA protocol. We've flagged the patient's chart, so that way, if it's an electronic chart, we've flagged that. And we've tagged the patient for the Sleep Navigator to do a consult with the patient, or in some hospital systems, it could be that that's a physician that's going to do that initial assessment of the patient. Now, the Sleep Navigator, again, the role of the Sleep Navigator is to, help with the identification, and moving to the next piece of this is to educate and coordinate. So, my recommendation is that the Sleep Navigator provide condition-specific OSA education to the patient. So if they're admitted to the hospital with a cardiology issue, then part of the education that the Sleep Navigator could provide would be related to cardiovascular issues and sleep apnea, just so it helps to tie their current condition to their potentially undiagnosed issue. Patient sleep assessment, complete and set patient expectations for the next step. So, I think it's important for the patient to, one, have education related to sleep apnea, but then you're setting the stage for the next few events that are going to occur to the patient so that they have an understanding and really have an expectation that, once I get out of this hospital, I'm going to get my sleep apnea treated. And I know that I'm either going to, most likely have an in-lab sleep test, or maybe I'm a great candidate for a home sleep apnea test. And then the Sleep Navigator really, after they've set the stage for the patient, then it's reviewing their assessment with the assigned physician. So whoever, whether it's a hospitalist or if it is a pulmonologist who is familiar with sleep apnea, then they can at least review that with the patient and ensure that there is appropriate documentation by both the Sleep Navigator and the physician that would be included in the patient's chart. And also making sure that there are orders for that patient post-discharge related to the sleep study. Because really what we want is for that patient to get an expedited sleep study, which is the next step. So diagnosing and treating. We really want to try to expedite the sleep test for that patient, because in particular, if it's a patient that might potentially become part of a readmission issue for the hospital system, we want to try to minimize the time from when they leave the hospital to when we get them on a PAP therapy device. I even have a potential recommendation of a potential bridge for that patient leaving the hospital and actually getting their payer-provided CPAP device. But essentially, the patient's going to get tested. They'll get their results reviewed, and then a plan of care is ordered for that patient. And then the patient's going to get their brand new payer-provided CPAP device, and then the work begins to get that patient adherent to their therapy. So there would be an expectation by the home medical equipment provider to ensure that the patient is on a device that can be monitored remotely, that they have a sleep coaching program, that they have an effective resupply program. One issue of non-adherence for patients with CPAP is that they don't necessarily have great supplies, and it could be that they get a hole in their mask and just decide to abandon CPAP therapy altogether. So you want to make sure you have sort of that qualifying criteria of the home medical equipment provider, but also that, now you've also got a sleep navigator who can assist the home care company in monitoring and coordinating services for that patient. So let's say that the patient has discharged from the hospital, they're post COPD exacerbation, they've been placed on therapy for the first time, there's an increase in respiratory rate for that patient, some non-adherence issues, then it really would be on the sleep navigator during that 30-day post-discharge window that the patient would be part of a readmission penalty to coordinate that patient back into an MD office visit versus showing back up at the emergency room. And then ultimately, you would want to track and report the outcomes. Let's say that you're screening your patients. There's 100 new sleep studies that are going through the program. You would just want to make sure those patients who might potentially be a readmission penalty patient are part of your tracking and reporting, so that you can ensure that at least if they do readmit to the hospital, it's not related to their sleep apnea. Now, a couple things, as far as a sleep navigator, I don't know that I don't know of any programs where sleep navigators necessarily monitor the patient post-discharge. I do know of one, Christina Weaver, I think, has one down in Florida where they do some monitoring of the patient in conjunction with the home care provider. But here we've got a sleep navigator who's now on duty. And we've got these new codes, and you see lots of information out there now about remote patient monitoring. Also, there's also a category called remote therapeutic monitoring. I just wanted to make sure that this audience at least knew that there were two different categories, and there's actually different CPT codes that are associated with those different types of patient monitoring. We do have the data and availability to rescue these patients once they leave the hospital, as long as we've gotten them through the diagnosis process and successfully on a CPAP device. One of the things I like to give as an example is that, for a patient, let's say that they didn't necessarily tolerate CPAP and they're on a bilevel device and they're newly diagnosed and on their treatment. Every single day, you're going to get adherence data, efficacy to make sure that the device is working for that particular patient. You're going to get minute ventilation, tidal volume, respiratory rate, all of that data coming in every single day, which gives you a snapshot into that patient's home to know whether, one, they're using their device, and two, is the therapy effective for that particular patient. So the Sleep Navigator, one of the things that I just wanted to mention, there is a new credential that is the CCSH, newer credential, let me say that, but I think that the right person for this particular role has that background either in sleep or respiratory or nursing. In some hospitals, they may want to consider a nurse for this particular position who has that CCSH, just so that they are able to, their scope of practice is certainly much greater than that, and some of the verbal orders that they're able to act on by a physician might justify the use of a nurse instead of a sleep tech, for instance. And by the way, there's a lack of sleep techs, and we need more sleep techs in the field. So we need more of us to move into these types of roles. So, back to this original slide about how you get started. So you also have to think about, from a home care perspective, who's going to provide the PAP therapy? How will the patients be monitored? Who's responsible between the sleep navigator or the home care company? And, if it is a sleep navigator, what access do they have to the patient? Are there multiple software platforms that are involved? And then most importantly, and I would say this is probably one of the critical points of this, is how do you track outcomes? Because ultimately, if you do get this patient diagnosed and on a therapy device, and now you've gotten them past this post 30-day discharge period, what's the long-term outcome for that patient? Because that's the kind of data I think that we need as an industry in order to justify to the U.S. Preventative Task Force to proactively screen patient populations is that we've got a patient who was undiagnosed. We diagnosed them, we treated them, and now post-discharge and long-term, that patient is a lower cost of care to the healthcare system. So I mentioned that I would give you an example of a very successful program and where I sort of stole their OSA protocol. But there's a hospital that, again, it's a very small hospital when you start to do some research on this particular facility. But they rolled out a sleep apnea screening program. It's only a 36-bed hospital, but you can see that the leaders created a task force to assess the tools and equipment that would be needed. They were able to justify adding sleep services. So I'm not sure that they even had a sleep program prior to the implementation of this program. They also expanded they were able to justify adding sleep services, and they expanded screening to their primary care clinic. So not only were they screening in the hospital, they started screening patients before they ever came to the hospital. Now, I think these are some interesting statistics here. A total of 3,985 surgical patients were screened, of which 94.9% had a preoperative assessment completion rate. So it must have been mostly mandatory in this particular case. Of those patients, 74.2% went on to need the OSA protocol. That's significant. So what we know is they screened their patients for sleep apnea. We know that there was a high probability of those patients who potentially had sleep apnea, and then they implemented the OSA protocol for the patient. And then 26.7% of those who had the orders placed were required to spend the night using CPAP. So some of the patients actually had to stay in the hospital due to the potential severity of their sleep apnea. So I think this is a great example, and I know today also, there's a big part of this that has to deal with the economics of rolling out this type of program. There are others who talk about sleep apnea screening programs. Massey Arrington out of Wellstar has a very successful Sleep Navigator program, has great economic data to go along with the justification and need for that type of role and program in their facility. But you can see here the total cost of the program, $161,000, $378,000 in yearly revenue was generated from this new program with a net gain of $217,000. To a small 36-bed hospital in a rural market, I think that's significant dollars. I mentioned Christina Weaver earlier. She also has been a champion for sleep apnea screening for a long time. And I mentioned, too, that I know that in her particular facility, they certainly monitored patients post-discharge along with the DME providers. And you can see her program had a 30% reduction in readmissions for newly identified sleep apnea patients over the last 4 years. And that was when this particular study was published back in 2018. So congratulations, Christina. She's been a champion for Sleep Navigators and sleep screening since that time. Now, another version of this, and I don't want to convolute the message, screen patient, get the Sleep Navigator to educate the patient, and then to coordinate the patient for diagnosis and treatment. But I wanted to at least give you one modified version of this that may not necessarily, it's just a little bit different model. So screen and protect, diagnose and treat, and then monitor and report. So we did leave out one section there. And I tried to streamline it into a timeline just to give you an idea of what this would look like for a patient. So essentially, they're going to answer the questions related to the stop bang survey. We're going to put the wristband on patients who are positive and initiate the OSA protocol where appropriate for the patient. Now, there wouldn't necessarily be a sleep navigator, and I know some hospitals that I've worked with, they just don't have the resources to be able to have a sleep navigator. So really the sleep program becomes more of a post-discharge activity for the patient. But they're still screening, they're protecting the patient while they're in the hospital. They have a plan of care for the patient at discharge. They implement a loaner pack program, or maybe you call it a bridge device, to get the patient from the hospital until they're on their payer-provided unit. There's ways to do that that I'd be happy to talk with anyone that would be interested in sort of learning how you pull that one off. There is, we want the patient to have expedited sleep testing post-discharge. Again, a treatment plan would be ordered for the patient based on the results. Patient's going to be set up on their CPAP. The patient is supported through their home care provider, and then it's monitor, coordinate, track, and report outcomes again. So you can see that this is just another variation. It does take out the Sleep Navigator, but again, there's some hospitals, there's just no resources to be able to do that. If you have a COPD or a CHF Navigator in your hospital system, I think there could be some dual activity of those folks who are in those roles, and they can, do some simple things like ask a stop bang survey as part of their initial assessment of the patient, and then as they are doing some of the post-discharge planning, they include sleep as part of the plan of care for that particular patient. I know that we talked earlier about my podcast, but again, I wanted to give you an opportunity to listen in. So there's a QR code on the screen. If you got your phone and want to scan the QR code, it'll take you to the podcast. Myself, Jerry George, and Emerson Kerr, we put out a new episode every other week, and we meet with sleep techs and people who are involved in the sleep industry. A lot of times it's learning how they got involved in sleep, and then what their role is and how they contributed in a major way to the field of sleep medicine. We all care deeply about this field that that we're all involved in, and the patients that we serve. And I think that you would enjoy the podcast. So feel free to take a look. I think that actually might even take you to the website, the sleeptechtalk.com, and give it a listen. Are there any questions? I think I left a few minutes for us to ask some questions. So any questions?
Yes, we do have some questions for you, Robert, and thank you for that presentation. That was fantastic. All right, let's get to it. All right, we have a question from Kathleen. Who is ordering the OP sleep test to be done post-discharge if the patient is being managed by a hospitalist group and not seen by a consulting MD in the hospital?
Yep. Was there a Sleep Navigator in that scenario?
Kathleen did not indicate that. Can you put that in the chat? Yeah.
Let me give you versions of that. So if there's a Sleep Navigator involved, the Sleep Navigator may need to meet with the physician who is the attending physician and educate them and give them their assessment of and get them involved in documentation related to that patient's specific issues related to the sleep apnea. And then you've got to have certain criteria in place, and maybe you even have a template that you help the physicians, and maybe there's even some pre-education prior to the launch of a Sleep Navigator program where you're educating physicians on the documentation that's required in order to justify ordering a sleep study post-discharge. But again, don't forget, you've also got to make sure you've got capacity in your sleep clinic or with your sleep physician to be able to see the increased number of patients that would come through the program because of the screening.
All right, great, thank you. And let's see here, next question. I'm a tech that would love to start a program like this, but it's a bit overwhelming. What is the first step that you would recommend?
Yes, so don't forget, it's just like eating an elephant, one bite at a time. So, and even as I have done this presentation over time, I always have to go back to, you just have to stay focused on getting the sleep screening program started in the first place. All of this navigation and education and coordination that goes on after, that all can be added. And it's going to be very nuanced. I've worked with hospitals where they do sleep apnea screening, and because the pulmonologists are already doing rounds on pulmonary patients in the hospital, they have no issue with doing, additional sleep consults as they're making the rounds. That's that one particular facility. So you have to sort of base the program on the nuances that are specific to your facility. And if you feel free to reach out to me, I'll make sure you have my contact information, and I'm happy to help answer any questions after the webinar today.
Yeah, here's a good follow-up to that, Robert. How do you get buy-in from the physicians in the hospital?
That's a good. I think it's data. I think there are enough clinical studies out there, and actually, can they still see my screen, Rachel?
Yes.
Okay, so I included in my slide deck, I actually put this in here, is a number of clinical studies that, I just selected these because I think these were relevant to this particular topic, but you can see OSA as an independent risk factor for hospital readmission. There are studies that show that you can keep patients out of the hospital if you identify them and get them on PAP therapy. There's diagnosis and treatment of sleep disorder breathing, hospitalized cardiac patients, a reduction in 30-day hospital readmission rate. That there is the clinical data out there to, I would hope that the physicians would want to do the right thing for the patient ultimately and implement this type of program. But I think at least at a minimum, you should be able to get them to buy into screening the high-risk patient population.
All right, great. So there are many different types of inpatient screening programs. Some choose to screen 100% of their patient populations with stop-bang. Some choose to focus on certain comorbid conditions such as CHF. Have you seen one model perform better than others? Or what is your recommendation?
Well, I'm certainly a fan of screening all patients because I know that we've all done sleep studies on patients that came into the lab and physically they may not necessarily have looked like they were going to have severe obstructive sleep apnea, and then you start the study and a couple of hours later you're rushing in the room with a CPAP mask because they've met the split protocol. So, I think you have to let the organization lead as far as what the tolerance is, in rolling this out to certain patient populations. Again, I'm definitely the fan of doing, all patients, because what's the harm in you screen the patient for sleep apnea, they screen negative with a stop bang survey, and you don't necessarily have to spend a lot of time. Good news, that patient is not high risk for sleep apnea based on their results. So then we can focus on the patients who are more at risk and potentially could be expensive to the hospital and healthcare system long term.
Great, thank you for that. All right, we have a question on RPM. So how would you sell billing for RPM in addition to sleep testing for better patient outcome?
Yeah, so that's where, again, there's a lot of parts to put to build a program. But today, at least as I understand it, remote patient monitoring can only be built through a physician practice, and there are software programs and companies out there that can equip physicians to get into that space. They provide software that has timers on it because there is a timing requirement to do remote patient monitoring. You have to spend a certain amount of time with a patient each month in order to bill for those services. Remote therapeutic monitoring is a little bit different. So there are some nuances, and again, there's different CPT codes. But I think I would seek out, and I'm happy to pass along at least a few of the companies I know that are in that space to anyone that wants to reach out to me afterwards. But again, the billing would need to occur through a physician's practice.
Okay, great. Thank you for clarifying that. You mentioned the CCSH credential. How do you feel it prepares a tech to perform the role of the sleep navigator?
Yeah, so I would say in general, the RPSGT doesn't necessarily give you the tools that you need to do that condition-specific education with the patient. It gives you the tools you need to perform polysomnography. The CCSH, I think, sort of takes it to the next level, where now you can talk about obstructive sleep apnea, but you can tie it in with cardiovascular disease or other types of health conditions. If it's a neurological issue for the patient, you can tie that condition back to OSA and help the patient put the two together. So that way it becomes more real to them, and they understand that in order to improve their primary issues, that they need to get this secondary issue taken care of as well.
And a follow-up to that, where did it go? How do you see tech's roles in the future?
Oh my goodness. Well, certainly the CCSH would be one, but if anyone who's paying attention to the one element of my presentation is that if you need volume in your sleep lab and you just don't have enough referrals that are coming into your sleep center, this is the way to do it. You implement the program, the patients are there. We know that there's this great undiagnosed patient population. This is the way to move them from, entering the hospital or entering the primary care clinic, like that healthcare system, the small healthcare system. It was so successful and the prevalence was so high in the hospital that they rolled it out to their primary care clinic. Can you imagine if, what your sleep center would look like if all your primary care physicians just asked, not even necessarily the stop bank survey, but let's say they just asked the question, do you snore? Are you overweight? Do you have high blood pressure or diabetes? Those three questions alone would impact the number of referrals that are coming to the sleep program. So
yeah, that's great.
To get back to the answer, we're going to need lots of sleep techs to still run nighttime sleep studies and to do lots of home sleep apnea testing.
Yes, thank you. Should my risk department be involved in creating a program like this?
100%. I think that's a fantastic approach, actually, because implementing that OSA protocol while the patient's inside the four walls of the hospital, to me, that's where it becomes a risk management opportunity. And they have to meet certain goals every single year in order to, they've got to have different programs that they're going to roll out each year. Why not let it be OSA and implementing this OSA protocol? But the good news is that the patients are going to be more protected while they're inside of the hospital, because otherwise they're leaving these patients who are undiagnosed, untreated, sleeping fully supine and unmonitored in a lot of cases, instead of going ahead and protecting the patient at least while they're there in the hospital.
Is there a rule of thumb you would use to identify the amount of patients at risk in the inpatient realm?
Every time that I've seen a proactive sleep apnea screening program implemented in a hospital system, 25% of the patients will screen positive and are undiagnosed and untreated.
Wow.
Every time. It's consistent, no matter where the hospital system is.
Really, that's interesting. All right, let me see here. I think I might have had another one that I missed. If anyone has any more questions, please get them in the question panel. There were a couple requests, Robert, for copies of your presentation, so we can follow up with, I don't know if you want to address that, or maybe we can follow up later to see if there were just specific slides. I'm guessing to try to use this as a way to promote with whoever needs to be convinced of implementing a program.
Yes, I'm happy to share. I think I'd like to just have people email me individually, and I'll send it to them. I'm
Sure.
happy to share it with you. I'd love to even talk to you about the different programs that I have personally been involved with. I know that we have Andrea Ramberg. I think she may be on the line too. Andrea was absolutely one of the most successful sleep navigators that I personally have come in contact with, and the role that she played in her healthcare system when I first met her, she was a significant contributor to the inpatient or the in-lab volume at her facility. So in fact, if you go way back in Sleep Review magazine, she's on the cover one year and was a bit of a rock star in that particular role. And I know she's a rock star at InsoData today.
She sure is. We love Andrea. One question, I don't think you covered this when we were talking about the CCSH, but someone was wondering what the qualifications are to get the certification.
Well, I know that there is a course. I think there was actually one, maybe even just last weekend, that you can go and take the course. But all of the requirements and things are posted online. So thank you, Angie, for sharing that. And I still have to go and take the course myself and get my CCSH. So I've been involved with these things, but not necessarily at the patient bedside. So I still have to get my CCSH as well.
Great. And yes, Angie confirmed that as well, that the books are listed on brpt.org as well. So that's great. Review courses for CCSH are through the AST. So yeah, thanks everyone for all of your helpful information.